Good morning. I am here with Dr. Lavard and Dr. Stankovic from European Bifurcation Club. After we have closed our section, European Bifurcation Club at C3, I think we had a very interesting meeting. I'd like Dr. Lavard, if you can give me the highlights of this morning section.
We had many topics, but I can say that at the beginning I was speaking, and several speakers like Goran were speaking also about the mature strategy, which is a provisional stenting strategy, which can be used in vast majority of patients. And I think we are going to understanding, especially through the pot, that bifurcation is not a big and a small tube. And this is, we know that from anatomists and physiologists since quite a long time in the club. But now we consider that the pot is not only to avoid a change in the wire outside, is also part of the strategy to rebuild a functional anatomy. I think I clearly feel that this now. We don't have any study showing that having 3 diameters is better than artificially creating 2 diameters. I don't know if we'll have one day, but certainly POC is accumulated a lot of advantage, giving a second of the third diameter to the stent that was implanted cross over the side branch, avoiding mistakes like exchanging the wires outside. Sometimes they have some cases like this, can reopen an occluded vessel when the stent chosen from the distal main vessel was too big. So giving a second diameter proximally is creating a window to go to the side branch. Also it's facilitating crossing the wire, even the choice of going towards the side branch through the most distal cell. So POT for me is and can be completed with KISS. The main advantage of KISS for me is if you choose 2 balloons from the 2 distal diameters, is positioning the carena back in its goose position to share the flow, which is its function. So this is the first point we have seen. Then we have seen imaging. I was very interested as usual by imaging coming mainly from our Japanese colleagues. They are now with 3D OCT or FDI, where they are able to have a 3D reconstruction of the situation at the levels of bifurcation. So we see the strut, we see the ring, we see the connectors between the rings, and we see, of course, the position of the side branch ostium, and we see how the wire is going towards the side branch. So it can it's frequent when you have a big side branch to have several different cells that are available for crossing on the longitudinal axis, but also laterally. And they can define very well where is the wire. And I remember a previous talk by Murasato saying that when you use our technique of pull-back wire to enter the side branch, we are entering in the distal cell amount around 70%. And if you are able to diagnose that you are in the wrong cell, you can do a second attempt. It's not real guidance because it's not live, but it can go up to 85%. I think probably will be impossible to go higher than that. But I think it's an important point because when you enter the distal cell, you are pushing metal in the side branch. And pushing metal in the side branch, even if it's 2-3 millimeters, you are stenting the ostium in the side branch. And you know that when a stent is positioned, is also supporting the few millimeters more distal. The vessel is not going to its true diameter immediately after the stent. And another thing that the stent is doing in the side branch is cells can elute some drugs on 1 or 2 or 3 millimeters, probably no more. And this can be important in simple bifurcation lesion. And in complement of this, they showed that also the importance of the connection. If the connection is in front of the side branch, you will probably, by conventional mean, will never be able to remove completely from the flow. And they describe a technique which is trying to push the strut, which are depending of the connection towards the side branch at the carena level. So we are not stanting in this situation. We are not stanting the side branch opposite to the carena. We are just pushing a strut on the other side of the carena on the side branch side. So it removes effectively the strut from the lumen, but it's not stanting the side branch. But when we are facing this situation, we know that we can do tap stanting, for example, with some protrusion, which is a validated technique. After that, went back on several presentations, the discussion of 1 versus 2 stents again. Of course, the discussion is not focused on simple lesion. I remember the trial of Dr. Chen definition was saying that 70% of bifurcation can be treated with provisional. So the question of at the beginning of the procedure, because something can occur, but the question, do we will have to put 1 or 2 stents, is only for 30% of bifurcation. Yes. And the discussion was moved a bit, especially in this session this morning, was moved to the left main, because of course the left main is a concentration of all the fear we have when we are treating other bifurcation. The fear of losing the side branch and losing the circ, I showed the case, is certainly can be certainly a very big problem, very big complication. So some operators are proposing alternative way of provisional stanting, which can be a double stanting technique, by stanting the side branch first. And stanting the side branch first is doing a crush. Of course, you can stent the side branch first and do a culotte. But this is a kind of provisional, because after the first stent, you still can choose the technique you will use. For decay crush, you put a stent at the side branch, of course, you will stent the main vessel. So we had some interesting data coming from bench, again, from Yutaka Ikichi, comparing in bench, and it's bench only, how the strut is distributed and inside the bifurcation after culotte and after decay crushing, double kissing crush. We can even say mini decay crush with minimal protrusion, and also mini culotte with minimal overlapping. And he was saying that the malapposition was more frequent at the place of the 3 layers in the decay crush, and recommended to have a really well apposition, guided by OCT, I presume, with high pressure and maybe a bigger balloon. And this discussion, of course, also of 1 versus 2 stent, mainly on the left main, was illustrated by 2 studies. The decay crush 5, that shows more reintervention in the group of provisional stenting, that I can understand, but there was, in my opinion, there was, as frequently, a methodological problem. The angiographic control was systematic, but was scheduled at 13 months, so 1 month after the endpoint, in favor of decay crush. And it was exactly in the study, in fact, it was at 360 days plus minus 50. So many of the patients has the angiographic control before the date of the endpoint. So, but this is I think, methodological problem, but probably has a minimal impact on the result. On the other side, and more difficult to understand, there are more MI, not periprocedural MI, in provisional than in decay crush. So, looking at all the data, I found that the side branch lesion length was in mean 16 millimeter. And I know, because I worked there in China, I know that patients treated there are very, very severe lesion, frequently, and was the case in this group in more than 60% of cases. And I understood very clearly. I can say that, of course, provisional, the classic provisional with minimal crossover to stenting cannot treat such a lesion. So regarding the fact that 47% in the provisional stenting strategy group had crossover, I imagine that in fact was not enough. Was not enough for the nature of lesions that were treated. So this is my explanation of this result for decay crush. So I imagine that we can now think about select a population, and probably they can do that better than us in Europe, because the lesion we treat are probably treated earlier and not so severe. We can imagine a study that will be systematic double stenting, both sides, beginning with the side versus beginning with the main. 100% treatment, double stenting, and we will see what are the problem of each strategy, maybe a lower success rate in provisional, we can imagine that, or more malapposition in the decay crush, and what will be the final result. And the other source of information about this morning was completely different, was coming from Excel, was versus 2. And the patient having only one stent in the left main are doing better than patient receiving 2 stents. But of course, this is not a randomized comparison, and probably these are not the same lesions. So this is what I heard this morning. There are some other information, but less important.
Yeah, actually, I think we can summarize that today the discussion is not better 1 stent, 2 stents. As you said, I think we have to go in that direction, that this is complex. Bifurcation should be done with 2 stents at the intention to treat. This is simple, should be done with provisional stenting. And I think also the importance of side branch, the clinical relevance of side branch is another key issue. And I would like to ask Dr. Stankovic whether it is expected to be discussed this year also at next EBC meeting?
Yeah, thanks for that question. I think European Bifurcation Club now is a mature club. Club was created in 2004. We had first meeting as a group of enthusiasts in 2005, and it was really mainly European. But now we understood the importance of exchange of information, exchange of knowledge and skills. So in the last couple of years, we really invite worldwide participation. And one of the hot topics last year was how to identify a relevant side branch. This could be part of the missing piece of the puzzle that we try to resolve, because so far we define bifurcation as one with significant side branch, but significant side branch needs to have better definition and better clarification. And there are 2 different modes. One is using scaling system, using fractional mass by CT before intervention. But for everyday practice, I think we need to work more and find something more simple and appropriate to be done peri-procedural. So I can guarantee that this year we'll try to incorporate significance of the side branch and maybe work on that level. If we identify this 30%, which could be considered for different strategies, 1 versus 2, probably in this 30% we will find answers for the next steps. It's important that really working as a worldwide group of people with interest in bifurcations, we were able in the last 24 months to really publish 2 consensus documents. One general on bifurcation treatment with Dr. Jens Lassen as the first author. Then this year, after the last EBC meeting, we published dedicated consensus document on left main treatment with Francesco Burzotta as the first author. And then we have 2 consensus documents, one on the IVUS use with Dr. Gary Mintz and Adrian Benning. So we have from both parts of the Atlantic really experts summarizing knowledge about the importance of IVUS guidance, especially for the left main treatment. And it's just accepted for publication also consensus document with Patrick Seruyus and Yoshinobu Onuma is the authors on OCT use in bifurcation and left main. So if we add Dr. John Ormiston consensus group, which published in Neurointervention consensus on bench testing, I think last 2 years we really published several very important papers which are actually first justifying the existence of scientific club like Bifurcation Club. And in these 3 days, 2 days and a half, we really extensively discuss, then try to summarize everything in the consensus statement, and then share it worldwide with all the colleagues. So I think this year we are meeting in October in Brussels, 12th and 13th, and I will try to make sure that interest is really maintained by high quality scientific publications. So I believe that's the best way, and the idea that was actually born by Dr. Yves Louvard, Thierry and Olivier Darmon in 2004 now came to really mature phase. Absolutely. That we are really working worldwide, not just for the Europe. If I don't know if you want to add something, you were actually, idea was yours.
Yeah, the future. You were asking me what will be the future. Probably the future is not me, because I'm now at the end of my career. But I think there's still work, and in two directions that we are speaking about. We don't have, except in DK-CROCH5, we don't have a randomized trial, not only left main, but also on bifurcation with big diameters. Some studies were scheduled for this, like Nordic 4, for example, was supposed to include patients with more than 275 millimeter diameter of the side branch. And in fact, what was included was 2.4 in mean. So we don't have information about the big bifurcation. For big bifurcation, it is not impossible that there is an advantage, even in moderate complex lesion, that there is an advantage to treat with double stenting. The data we have are from Excel, is not randomized, and we don't have big study on the topic of big bifurcation with big side branch. I mean, at least 275, maybe more. So these are, majority of them are left main, but we can find big bifurcation outside the left main. And so we need to work on this. The history of left main stenting is not finished. It's not beginning, because today we are allowed to treat selected patients, the patient you can select. In the past, we were treating, for example, in the 90s, we were treating patients refused by surgery, and very frequently they were very complex. So the information we got are not the same that the one we will have in scheduled patients. And the second point is, yes, I think we'll move forward with physiologic evaluation and with imaging. What we have today with OCT is not really completely guidance, because we have to make the injection. It was shown this morning that we can reduce the amount of contrast by using dextran, which is interesting to evaluate. Was not evaluated in the club, can be. And the other point is physiologic evaluation. We tried last year to have a part of EBC on this, and accepted the FFR coming from CT scan recombined with the actual angio in order to know what is the FFR at the precise point, which is very interesting and not so easy to do in practice. We are thinking about guidance, true guidance with FFR, FFR wires, for example, being used as workhorse wire during the procedure. So these are things that in the future can be done. Also, I think that will be what will be have an importance in the future is patient-specific simulation. So to test hypothesis with the same patient issue that has different techniques, and so this is an option. Can be also, if it becomes very easy to perform, maybe we'll have the opportunity to do a virtual pre-treatment. That will be perfect for young operators. They will learn the technique on a virtually before doing in the patient. So we have some new things to perform in this club.
I totally agree with you that most progression or evolution will be coming from physiological and intravascular imaging. The main problem is still the cost of these devices and to use it routinely in the cath lab. But I think also research in that direction is already there, because I think instead of FFR, some measurement, physiologic measurement without hyperemia can be come in, which could be cheaper, as well as new modalities of imaging. I don't know. But
has not
really
been evaluated yet.
Yes,
Because we are IFR, we hear a lot of things about IFR, but not in bifurcation.
Yes. So I think the future, of course, is very brilliant, and I hope we'll continue to have your contribution as well, not only individual, also from European Bifurcation Club. Thank you very much for this.
Thank you very much.
Thank you, Imad.